when German military physician Dr. Friedrich Weber was captured in North Africa in 1943 and transported to a Canadian POW camp. He expected to be segregated from medical practice, perhaps assigned to menial labor or at best allowed to treat fellow prisoners with minimal supplies. But within weeks, he found himself working alongside Canadian doctors in a civilian hospital, treating Canadian patients, accessing modern equipment and medications, and being consulted on complex cases as if the war didn't exist. Over 400 German military doctors and medics were held in Canadian POW camps during World War II, and the treatment they received challenged everything Nazi ideology had taught them about racial hierarchies and democratic weakness, transforming many from committed believers in German superiority into advocates for international medical cooperation, who would spend their post-war careers building bridges between former enemies. The story begins not with magnanimity, but with pragmatism. In a Canada facing severe physician shortages as doctors enlisted to serve overseas, leaving rural communities and even some urban hospitals desperately understaffed, at precisely the moment when wartime industrial accidents and civilian medical needs were increasing, the medical crisis in Canada by 1943 was genuine and growing worse as the war dragged on. Approximately 40% of Canadian physicians had joined the military medical services, serving in field hospitals from Sicily to Normandy, on hospital ships, crossing dangerous Atlantic waters, and in casualty clearing stations where they performed a battlefield surgery under conditions that would have been unthinkable in civilian practice. The doctors who remained in Canada found themselves overwhelmed, covering multiple hospitals, working shifts that extended beyond human endurance, and watching patients suffer or die because there simply weren't enough medical professionals to provide adequate care. Rural areas were hit particularly hard because small towns that might have had one or two doctors now had none, forcing residents to travel hours for medical attention or simply go without treatment. The Canadian Medical Association had been lobbying the government for solutions, proposing everything from accelerated medical school programs to recruiting physicians from neutral countries. But every proposal ran into practical obstacles, or political opposition. The idea of using German POW doctors to fill gaps in Canadian medical services was controversial from the start and required careful navigation of Geneva Convention provisions, military security concerns, and public opinion that was understandably hostile to the idea of enemy doctors treating Canadian civilians. The Geneva Convention allowed prisoners with specialized skills to be employed in work related to their expertise, and medical practice certainly qualified. But the convention also required that such work be voluntary and that prisoners not be placed in positions where they might access sensitive information or pose security risks. The Canadian Military Medical Services conducted careful screening of captured German medical personnel, reviewing their credentials, assessing their ideological commitment to Nazism, and evaluating whether they could be trusted to work in civilian medical settings. From the several hundred German doctors and medics held in Canadian camps, approximately 120 were eventually cleared to work in Canadian hospitals, a selection process that prioritized medical competence and excluded anyone with documented involvement in war crimes or fanatical Nazi ideology. Dr. Friedrich Weber's journey from captured enemy to practicing physician in a Canadian hospital illustrates both the process and the psychological transformation it produced. Weber had been a general practitioner in Munich before being drafted into the Wehrmacht Medical Corps in 1941, serving first in Russia and then in North Africa, where Rommel's Afrika Korps was fighting its losing battle against British and American forces. He'd witnessed the brutality of the Eastern Front, had treated German soldiers suffering from wounds and diseases in conditions where medical supplies were chronically inadequate, and had absorbed Nazi propaganda about racial hierarchies and the weakness of democratic nations. When he was captured near Tunis in May 1943, weak from dysentery and exhausted from months of retreat, he expected harsh treatment or at best minimal care. Instead, he received immediate medical attention from British medical personnel, was given food and water, and was processed through a system that seemed remarkably bureaucratic inhumane for an organization dealing with enemy combatants. The transport to Canada took weeks, with Weber and hundreds of other prisoners crowded onto a ship that crossed the Atlantic in convoy, constantly alert for U-boat attacks that could send them all to the bottom. During this voyage, Weber provided medical care to fellow prisoners, treating seasickness, infections, and injuries with the limited supplies available. Work that British guards noted and documented in records that would later influence decisions about his employment. Upon arrival in Canada, an assignment to a camp in Ontario, Weber underwent interviews where Canadian medical officers assessed his qualifications, reviewed his medical knowledge through examinations that tested both theoretical understanding and practical skills, and evaluated his willingness to work in Canadian medical facilities. Weber's fluent English, learned during medical school when he'd studied British and American medical journals, made him particularly valuable because language barriers were significant obstacles. For many German doctors, the hospital where Weber was eventually assigned was a small facility in rural southwestern Ontario that served a farming community and had been operating with a single elderly physician who was covering what should have been a 3-doctor practice. The arrangement required Weber to live in guarded quarters at a nearby military facility, but to work during the day at the civilian hospital under supervision of the remaining Canadian physician. The first day, Weber walked into that hospital, wearing civilian clothes provided by authorities to avoid alarming patients, but accompanied by a military guard who waited outside. He experienced profound cognitive dissonance. The facility was clean, well-lit, and equipped with modern medical technology, including X-ray machines, surgical equipment, and pharmaceutical supplies that exceeded what he'd had access to in German military hospitals. The Canadian doctor who greeted him, Dr. James Patterson, shook his hand and spoke to him as a colleague, discussing cases and asking Weber's opinions as if they were peers rather than captor and prisoner. The patients Weber treated in that Canadian hospital had no idea initially that he was a German POW, knowing only that a new doctor had arrived to help with the backlog of cases that had been building during the physician shortage. Weber examined children with respiratory infections, elderly patients with cardiac conditions, farmers with injuries from agricultural accidents, and women dealing with pregnancy complications, providing medical care that was indistinguishable from what any Canadian doctor would have offered. The work was both professionally satisfying and psychologically disorienting because it forced Weber to confront the humanity of people he'd been taught to consider enemies, to recognize that Canadian children deserved the same quality of care as German children, and to acknowledge that medical science transcended the nationalist ideologies that had plunged the world into war. In letters he wrote to his wife in Germany, carefully censored by Canadian authorities, Weber described feeling simultaneously grateful for the opportunity to practice medicine and guilty about treating enemy civilians while German soldiers and civilians suffered. The medical collaboration between German POW doctors and Canadian physicians produced unexpected benefits beyond simply filling staffing gaps. German medical training in the 1930s and early 1940s had emphasized different approaches and techniques than British-influenced Canadian medicine, and the exchange of knowledge went both directions. German doctors brought experience with battlefield trauma surgery, techniques for managing infections in resource-limited environments, and familiarity with medical challenges that came from operating in extreme conditions. Canadian doctors shared advances in antiseptic procedures, anesthesia techniques, and pharmaceutical developments, including the early use of penicillin, which was becoming available in Allied nations, but which German doctors had limited experience with. Dr. Patterson, who worked alongside Weber for over 2 years, later wrote in his memoir published in 1967 that he'd learned as much from his German colleague as Weber had learned from him, describing their relationship as a professional partnership that transcended wartime enmities through shared commitment to healing. The ethical questions raised by German POW doctors treating Canadian civilians were complex and generated ongoing debate within medical communities and among the general public. Some argued that using enemy doctors was pragmatic and humane, that healing transcended nationality, and that preventing suffering is more important than maintaining rigid categories of ally and enemy. Others contended that German doctors should be restricted to treating fellow prisoners, that allowing them to treat Canadians while Canadian doctors served overseas was inappropriate, and that some German medical personnel might have been complicit in Nazi medical experiments or other atrocities. The screening process attempted to address these concerns by excluding anyone with documented involvement in unethical practices. But the imperfect information available during wartime meant that screening couldn't guarantee absolute certainty about every individual's background. The reality of Nazi medical crimes would only become fully apparent after the war, when Allied forces discovered the extent of medical experimentation in concentration camps, forced sterilization programs, and the systematic murder of disabled people in the T4 euthanasia program. These revelations would cast retrospective shadows over all German medical personnel, raising questions about what they knew, what they participated in, and whether the medical profession in Germany had been corrupted beyond redemption by Nazi ideology. The German doctors working in Canadian hospitals during the war were generally not involved in these atrocities, having been military physicians treating soldiers rather than camp doctors or participants in eugenic programs. But the association was impossible to entirely escape once the full scope of team Nazi medical crimes became known. Dr. Klaus Hartmann, another German POW physician who worked in a hospital in Manitoba, described in post-war interviews the psychological journey of reconciling his identity as a healer with the crimes committed by his profession under the Nazi regime. Hartmann had been a pediatrician in Berlin before the war, serving in military hospitals where he treated wounded soldiers, but also occasionally treated civilian casualties brought in from bombing raids. Captured on the Western Front in 1944, he was transported to Canada and eventually assigned to work in a children's hospital in Winnipeg, where he treated polio patients, childhood infections, and congenital conditions. The work was deeply meaningful to him, returning to his specialty after years of military service. But it was also haunted by knowledge of what had been done in the name of German medicine. When news of Nuremberg trials reached Canada in 1946, including testimony about medical experiments, Hartmann reportedly broke down crying while on duty. Overwhelmed by shame that his profession had been perverted to serve evil, the Canadian nurses who worked alongside German POW doctors had their own complex reactions to these professional relationships. Many nurses had brothers, husbands, or fathers serving overseas fighting Germans, making it emotionally difficult to collaborate with enemy doctors, even in medical contexts. Some nurses requested transfers rather than work with Germans, a choice that administrators generally respected. Others approached the situation with professional detachment, treating German doctors as colleagues whose nationality was irrelevant to their shared medical mission. A few developed genuine friendships with German doctors, relationships that continued through correspondence after the war ended, and prisoners were repatriated. Nurse Margaret Thompson's diary from her time at a hospital in Nova Scotia, where a German POW doctor worked, was donated to provincial archives. Described her evolving perspective from initial hostility to grudging respect to eventual friendship, writing that she'd come to see Dr. Hans Müller as a decent man trapped by circumstances beyond his control rather than as an enemy. The surgical skills of some German POW doctors proved particularly valuable in Canadian hospitals that had been unable to perform complex procedures due to lack of qualified surgeons. Dr. Ernst Richter, who had been a prominent thoracic surgeon in Hamburg before the war, was assigned to work at a hospital in British Columbia, where he performed surgeries that saved lives and advanced surgical techniques in the region. Richter's skills with chest and lung surgeries, honed through years of treating battlefield trauma, were directly applicable to civilian cases, including tuberculosis patients who required surgical intervention. The operations he performed were documented in medical journals, though his identity as a German POW was not disclosed in publications until decades later. Richter's case raised particular questions about recognition and credit. Because his contributions to Canadian medicine were significant, but occurred while he was officially an enemy prisoner, creating ambiguities about how his work should be acknowledged.